give a minute more. Maybe people are just trying to log in. All right, so good evening. Welcome to the Grand Rounds. Today we have exciting Grand Rounds in store. Before we go into our presentation and introducing our guest speaker today, it's my privilege to present the details for today's Grand Rounds. Again, it will be housed into the website where you will be able to see this for the next 12 hours. So hopefully people who are going to be able to catch and answer the questions that will be presented in form of the CME question and answers would be able to get the benefit from today's presentation. The CME credit requires you to text at 12472 and to the number 888-816-4893. And the deadline is within 12 hours in form of an SMS message with an active profile that is needed in the Rutgers Cloud CME. And also we offered the MOC point. And for today's presentation, for physicians who want to have their MOC points reflected at their ACGME websites, please go in and complete the step 1 and then have a brief quiz. And this quiz link will be available in the chat website subsequently as well. But please remember the room code is future19, future19. And that will allow us to then go back to the highlight of today's presentation. I'm going to go ahead and invite Dr. Prem Soman to come into the spotlight. Dr. Soman, welcome. Prem is a very close friend, mentor, and colleague. We have worked together at ACC, and it's my sheer privilege that he's today going to give us his clinical knowledge on an important disease, cardiac amyloidosis, and how imaging has really opened up new methods for understanding the disease and predicting and finding them in the clinical population. Dr. Soman is a tenured professor of medicine and clinical and translational science, and he's the associate chief for faculty development in the Division of Cardiology at the University of Pittsburgh. He also directs the nuclear cardiology program and the multidisciplinary cardiac amyloidosis center, and also the advanced cardiac imaging fellowship at the Heart and Vascular Center in the University of Pittsburgh Medical Center. Dr. Soman came from India. He did his training at Jawaharlal Nehru Medical College in Karnataka University and the Postgraduate Institute of Medical Education in Chandigarh in India. Chandigarh is a city in North India. And subsequently, he moved to United Kingdom for medical research, and he was at the Northwick Park Hospital, and where he completed his PhD and fellowship of Royal College of Physicians. He subsequently moved to the US and did a fast-track residency at Lehigh Valley Hospital in Pennsylvania, and then his fellowship in cardiology and cardiac imaging in Boston at Tufts Medical Center. And Dr. Soman subsequently has had a prolific career, and his research interest has been focused on imaging of coronary artery disease and LV dysfunction, LV dysynchrony, and cardiac amyloidosis. He runs a very busy program of nuclear cardiology and nuclear cardiology services at UPMC Health System, which performs over 35,000 nuclear cardiology studies annually, and has a very reputable stature internationally for tremendous quality in his program. He has received several foundation and career development grants from several international societies, and has a record of sustained funding from the industry. He has over 130 publications in the field. And he also, despite his extremely busy career and in education, and is very well renowned as an educator, he's also performs multiple other tasks, including being the associate editor of Circulation Cardiovascular Imaging, and he was the past associate editor at the Journal of Nuclear Cardiology. He has been awarded with many prestigious honors. Some of them are the Herman Blagard Award for lectureship at the Society of Nuclear Medicine, and in 2018, the title of Master of American Society of Nuclear Cardiology. In 2022, he was awarded the Outstanding Educator Award and lectureship for extraordinary and consistent educational contributions in the field of nuclear cardiology by the Cardiovascular Council of Society of Nuclear Medicine. And he has held multiple national and international leadership positions, including being the president of the American Society of Nuclear Cardiology and chair of ACC Imaging Council, where I had the distinct privilege to work with him very closely when I was working through some of the tasks in innovation at the ACC. With those notes, Prem, it's an honor, it's a privilege to have you as our speaker, and we're really looking forward to a wonderful educational session from you today. Prem.
Partha, thank you so much, and good evening, everybody. It's such a pleasure and such an honor to speak with you this evening. And I'm particularly happy to do this as the guest of my dearest friend, Partha, who I think we've known each other. It go back a long way. The number of years are too many to count. So I'm going to talk about cardiac amyloidosis. This is going to be a clinical talk with some insights from molecular biology and basic science. And as you know, there have been a great number of exciting developments in the field of cardiac amyloidosis. But believe it or not, it all started many years ago with the simple petunia flower. And in the 1980s, a plant biologist by the name of Richard Jurgensen, who was also an avid gardener, and he was a plant geneticist, decided that he wanted to create petunia flowers that were more beautiful, a deeper purple color. And to do this, he injected into his petunia flowers an additional copy of the gene that encodes for pigment synthesis, thinking that he will have beautifully colored petunias. And to his utter surprise, he found that most of his petunias bloomed white. And this was the first observation that externally introduced genetic material, instead of being complementary to the native genetic material, can actually inhibit it. And with this observation, the story of RNA suppression was born. And it was many years later that the Nobel Prize for Medicine in 2006 was shared by Craig Mello from UMass and Andrew Fryer from Johns Hopkins for actually creating specific mRNA sequences called small interfering RNAs that could be introduced into C. elegans to suppress very specific gene mechanisms. And then it took another 10 years before the first RNA silencing therapy, patisiran, was approved for the treatment of familial amyloid polyneuropathy in August 2018. Soon afterwards, in October 2018, another RNA silencing therapy, an antisense oligonucleotide this time, was approved, this time again for familial amyloid polyneuropathy. And in the next year, FDA approved what we've all become familiar with, and that is tafamidis, a stabilizer for the treatment of transthyretin amyloidosis, this time for both wild type and hereditary disease. Now, paralleling these extraordinary developments in pharmacotherapy, there have also been very, very exciting developments in our diagnostic capabilities for cardiac amyloidosis. And let me illustrate this with a case. And this is a gentleman who was 51 years old and was quite healthy until he presented one summer night with new atrial fibrillation and severe congestive heart failure. And he told us that his father died of polyneuropathy. And in fact, he knew that he had the most common mutation that produces familial amyloid polyneuropathy, which is the Val30M mutation. His ECG showed atrial fibrillation and a left bundle branch block. His echo showed several features of cardiac amyloidosis, which I will go through. But when we went back to him and asked him whether his father, in addition to a polyneuropathy, had cardiac involvement, he said he actually did not know. This was never confirmed because his father did not want a cardiac biopsy. And at that time, a decade before this gentleman presented, the only way of confirming a diagnosis of cardiac amyloidosis was with a cardiac biopsy. This gentleman, however, was admitted at night, had an echo first thing in the morning, and then the same day went down to a nuclear lab, not a lot of fanfare, had a technetium paraphosphate scan, and this confirmed the diagnosis of cardiac amyloidosis, and the diagnostic confidence was approximately 100%. And I say approximately because at that time, we had not yet gotten back his serum studies to exclude AL amyloidosis. So in a span of a decade, this case illustrates how PYP imaging has been transformative for the field of cardiac amyloidosis. Now, amyloidosis, as you know, is a protein misfolding disease and can occur as the result of the misfolding of a number of proteins. But irrespective of the protein of origin, all amyloid looks pretty much the same under the microscope. And here is the typical apple green birefringence of amyloid when stained with Congo red that we're all become familiar with and viewed under polarizing microscopy. Now, the majority of cardiac amyloidosis is derived either from AL or light chain amyloidosis or ATTR amyloidosis, which is going to be the focus of my talk today. And ATTR amyloidosis, as you know, exists in a variant form and a wild type form. These two forms together comprise more than 95% of cardiac amyloidosis. And occasionally, less than 5% of the time, there are some other varieties derived from apolipoprotein A, gelsolin, and fibrinogen alpha chain, and so on and so forth. Now, AL and ATTR amyloidosis, as you know, are very different diseases with very different prognosis. And one of the recurring themes during this talk will be the importance of making a distinction as we evaluate patients between AL amyloidosis and TTR amyloidosis. Now, TTR amyloidosis exists in a hereditary form, which is inherited as an autosomal dominant disease, can present either as a cardiomyopathy, a polyneuropathy, or a combination of both. Whereas wild-type TTR amyloidosis is predominantly a cardiac disease, although increasingly we are recognizing that there is secondary involvement, certainly of the tendons, but also perhaps of the nerves as well. Now, the TTR gene is a small gene, and it is located on the long arm of chromosome 18. And the nomenclature, the scheme for the nomenclature is based on the point mutation, so that V30M is the substitution of methionine for valine at the 30th position on the gene. Those of you who work in the field would no doubt have recognized that many gene analysis studies will now call it PV50M. And this is because of the current standard of including a 20 amino acid signaling peptide in the amino acid counting. Now, here are some of the better known mutations. There are more than 120 mutations. The VAL122 or 142 isoleucine mutation is the most common mutation in the United States, and in fact has a prevalence of approximately 4% in the African American population. Now, obviously, 4% of the African American population don't have cardiac amyloidosis. So clearly the penetrance is not complete, but we know that it's age dependent. And the age of onset is very similar to wild type amyloidosis. Another common mutation that exists in the United States is a T60A mutation. This is a mutation that is prevalent in the Irish population in the United States, and it's a mutation that originated from Donegal in Ireland. Today, we know that wild-type transthyretin amyloidosis is not a rare disease, and it may exist in up to 13% of patients with HFpEF and thick ventricles, and in certain specific populations, such as aortic stenosis with a low gradient, particularly paradoxical low gradient aortic stenosis, a distinct subgroup of this population also now is recognized as having transthyretin amyloidosis. So the suspicion for cardiac amyloidosis most often arises from echo and from the finding of a thick left ventricle in the echo. This is a particularly non-specific finding. But when the thick LV is associated with usually a small pericardial effusion, as you can see in this image, and a thick interatrial septum. Now, the normal interatrial septum is about 6 to 8 millimeters thick. Most patients with amyloid will have a thicker septum. This combination of a thick ventricle with a small pericardial effusion and a thick interatrial septum, particularly in the context of typical or common ECG findings, should make one think of an infiltrative cardiomyopathy. Now, we're all very familiar with the low voltage that is associated with amyloid. And when a low voltage ECG is present with LVH, that's pretty pathognomonic of cardiac amyloidosis. But I want to say here that a low voltage ECG is fairly uncommon in amyloid. And if we rely on the presence of a low voltage ECG to make the diagnosis, we will miss it more often than make it. Only about 25% of patients with ATTR amyloid and about 50% of patients with AL amyloid actually have a low voltage. And in fact, about 20% of patients will have overt LVH on the ECG, which therefore is not a good criteria to exclude AL amyloidosis. Common findings are a pseudoinfarct pattern and AV blocks. There are a number of other echo findings that are common in patients with amyloidosis. Almost everybody with an infiltrative cardiomyopathy will have low mitral annular velocities. In fact, a normal diastolic function is almost incompatible with the diagnosis of cardiac amyloidosis. Now, I also want to point out here that asymmetrical septal hypertrophy can occur in cardiac amyloidosis, and often, in fact, in my clinic, patients have been initially mistakenly diagnosed as HCM before somebody realizes that this is cardiac amyloidosis. Another important finding is biatrial enlargement, and I want to point out to you here not just the size of the atria, but also the mechanical dysfunction, which is very profound in these patients because of atrial infiltration with amyloid, and this probably explains the very, very high prevalence of stroke and embolism in patients with atrial fibrillation and ATTR amyloidosis, a risk that is not predicted very well by the CHAD score. And in our amyloid center, for example, we're actively looking for atrial fibrillation, occult atrial fibrillation of any duration. And if we find even transient atrial fibrillation, we have a very low threshold for instituting anticoagulation. Now, we'll also become very familiar with this apical sparing pattern of longitudinal strain abnormality, which in the original paper from Cleveland Clinic was reported to have a very high sensitivity and specificity. We use this, but I think most centers now recognize that while it's a useful corroborative finding, these high sensitivities and specificities we're not able to reproduce. In fact, recently showed that this is a common finding in patients with, say, for example, chronic kidney disease, where the specificity of this finding is quite low, with still a relatively preserved high sensitivity. Now, the sensitivity of this finding is almost 100% in patients without chronic kidney disease, but it is lower in patients with chronic kidney disease. And there are a number of other conditions that today we know that can produce an apical sparing abnormality. I want to point out here that this relative apical sparing type of abnormality is less specific than the typical apical sparing type of abnormality that is shown here. So today we know that there are a number of red flags, clinical constellation of signs and symptoms that should make one think of cardiac amyloidosis. The typical presentation, of course, is preserved ejection fraction with unexplained LVH in an older patient. And it's important to remember that unlike our knowledge base about a decade ago, when we thought that this was exclusively a disease of the elderly male patient, about 10% of patients are female. And if this constellation is associated with diastolic dysfunction, AV blocks, and particularly bilateral carpal tunnel, this is very suggestive of cardiac amyloidosis. LVH with persistently elevated troponins is another tip-off. Older patients older than 65, first diagnosis of HCM, even with asymmetrical septal hypertrophy, as I mentioned, and of course, these other non-specific findings. And then some specific signs, such as this periorbital petechiae, which is almost pathognomonic for AL amyloidosis, macroglossia with tongue indentations, and unheralded tendon ruptures should all make you think of amyloid. Now, cardiac MRI is very helpful and is able to demonstrate all the morphological abnormalities that are seen in echo. The typical amyloid patient shows extensive subendocardial late gadolinium enhancement, the classic the tram track pattern. It's typified by a high T1, a high ECV, and a peculiarly abnormal kinetic profile of the gadolinium, where it becomes impossible to null the myocardium so that the myocardium looks brighter than the blood pool. Now, the higher the ECV, more the sensitivity for cardiac amyloidosis. And I'll talk a little bit more about this, but note, it's important to understand the performance characteristics of different diagnostic tests. And here you can see that the specificity is lower than the sensitivity. So when we choose different tests in our evaluation of a patient, this is really important to understand. In addition to its diagnostic value, a high ECV has particularly powerful prognostic value in patients with cardiac amyloidosis, as was shown by my colleagues Timothy Wong and Eric Shelbert from here some years ago. Now, as you know, the myocardium has both intracellular and extracellular spaces, and this extracellular space is the interstitial space and the plasma. And this is where the hematocrit becomes important in our estimation of ECV. I'm not an MRI expert, but I wanted to say that the native T1 values are affected by a number of things, including fibrosis, infiltration, edema, hypertrophy, so on and so forth. But the ECV is specific for the extracellular space. And the expansion of the extracellular space can be seen in a number of conditions, but it's rarely above 45. And by the time it reaches 50, this is very, very suggestive of cardiac amyloidosis. Now, the T1 values vary depending on the vendor and the software and the system, but the ECV is more reproducible across the systems. And so the higher the ECV, the more likely the patient is to have cardiac amyloidosis. Now, I could do an entire talk about DPD or PYP scanning. DPD is the PYP analog that is available in European countries. In the United States, the bone scanning agent that is used for cardiac amyloidosis is PYP. And today, I'm going to just point out a few important pearls when you use PYP. The first of these is that the diagnosis of amyloid using PYP should be based on SPECT imaging and not just on planar scintigraphy. The use of planar scintigraphy alone for the diagnosis of PYP is a thing of the past. Now, when I teach PYP to our fellows, I say that a positive PYP looks like a normal perfusion scan. So if you did a systemib scan or a tetraphosphine SPECT scan, that looks like a positive PYP scan. If I didn't tell you that this was PYP, you could mistake this for a myocardial perfusion scan. And when a PYP scan looks like a positive, like a normal myocardial perfusion scan, that is when it is unequivocally a positive scan. Now, it should not look like a MAGA scan. Now, here again, in the field of view, there's a lot of uptake of the tracer, but it doesn't look like a positive perfusion scan. In fact, it looks like a MAGA scan, and this is because the tracer is in the cavity and not in the myocardium. Now, both of these patients will have a positive planar scan. Looking at the planar scan alone, it is not possible to distinguish this patient from this patient, okay? So this patient has ATTR cardiac amyloidosis if the serum is negative. This is a false positive planar scan because of the persistence of tracer in the blood pool. Now, the diagnosis is made, and this is really important, by a combination of a positive PYP scan and a negative serum study for AL amyloidosis. Now, this cannot be overemphasized. AL and ATTR are so very different, and a diagnostic mistake here, as you know, can have very serious consequences. Now, in a typical setting, a positive PYP with the negative serum obviates the need for a biopsy in most patients, provided the setting is typical, the clinical setting is typical, and the serum studies exclude AL amyloidosis. Now, the full complement of studies that allows us to exclude a paraprotein with a high degree or high negative predictive value is the following: free light chains and their ratio, serum and urine immunofixation electrophoresis. If all these are negative, you can exclude a paraprotein and therefore AL amyloid or multiple myeloma with about a 99% negative predictive value. Note, however, that the standard SPEP and UPEP are not sensitive enough for this purpose. If you're using electrophoresis, it has to be immunoelectrophoresis for this purpose. Of course, the other way of distinguishing AL and ATTR is biopsy and amyloid typing. There are a number of ways to do this, but the current gold standard, the most specific method, is laser microdissection with mass spectrometry, which I think even today is done for clinical purposes only at the Mayo Clinic. Certainly all our samples go to the Mayo. So critical to differentiate AL from ATTR. Now, there are a number of situations where one has to be vigilant for a misdiagnosis of cardiac ATTR by PYP, and I'm going to summarize all of those on this slide. First, as I said, is a positive PYP does not equate to a diagnosis of ATTR unless AL is excluded with serum studies. A positive PYP, a planar scan, may also be due to blood pool uptake, therefore SPECT has to be performed. And finally, we now know that there are some very unusual gene mutations. These are the phenylalanine mutations. And I don't have time to go into the details, but because of the amyloid fibril composition in these gene mutations, these may be associated with a negative PYP scan. So in our population, if there is a clinical suspicion of TTR amyloidosis, We perform the PYP scan, we perform the serum studies for AL, and we sort of routinely perform gene testing in all these patients. And this complement of testing is useful and convincingly excludes cardiac amyloidosis. Now, there are a number of PET compounds that are being tested. None of these are in the clinical realm for cardiac amyloidosis, but I put this slide up here to say that the bone-seeking tracers, which is PYP in the United States, and I'll make a note here and say that the most commonly used bone tracer in the United States is MDP, and MDP is not useful for the diagnosis of cardiac amyloidosis. Really important point, MDP is not useful. But the bone-seeking tracers are able to distinguish between AL and ATTR amyloidosis. All other techniques, including the PET tracers, CMR and echo, cannot distinguish between ATTR and AL. And so, as I mentioned, in the typical clinical setting, if you've excluded AL amyloidosis in our center, most patients with a positive PYP, we don't biopsy. Now, this slide, I want to make a point here, shows you that Congo Red, which is actually a thioflavin T analog, and all the PET tracers that are thioflavin T analogs do not distinguish between ATTR and AL amyloidosis. Now, the bone-seeking tracers, we don't quite know what their mechanism of binding is, but they do distinguish between ATTR and AL. And why is this? Now, we know that the secondary structure of amyloid, this is one instance of the clinical utility of the structure-function relationship. The secondary structure of the amyloid fibril is this cross-beta-pleated structure. And the thioflavin analogs bind based on this beta cross-pleated structure. And this is why all the dyes and the imaging tracers that bind to amyloid based on the cross-beta pleat structure do not distinguish between ATTR and AL amyloidosis. Our lab, along with some other labs, were trying to establish the binding mechanism of PYP to TTR, and this, I think, will give us some insights into the structure-function relationships there. So how do we decide among these various imaging modalities? If the clinical suspicion is TTR, we start with a PYP scan and serum studies and gene studies. Whereas if the primary diagnosis based on the clinical presentation is AL, or if it's a younger patient with a much broader diagnosis of left ventricular hypertrophy, we start with a CMR, and then we go down these paths. Note that for the diagnosis of AL amyloidosis, it is important to establish two things. One is a monoclonal plasma cell expansion, which is by serum studies showing an increased serum-free light chains and immunofixation showing an M spike, and with a bone marrow biopsy showing plasmacytosis. These three establish the presence of a monoclonal proliferation of plasma cells. However, to make a diagnosis of AL amyloidosis, in addition to showing a dysproteinemia, it's important to show tissue deposition of amyloid. And here I show you the yield of the different tissue biopsies. Now, I will tell you that the most expedient way of making the diagnosis is to biopsy the tissue that is clinically affected. And in my life, that's usually the myocardium. So when we come to this right-hand side of the algorithm, we are still performing a fair number of myocardial biopsies. That is sort of a whirlwind view of some important aspects of the different diagnostic approaches. And in the next 15 minutes or so, I'm going to do the same thing with some of the important and exciting developments in the pharmacotherapy of cardiac amyloidosis. Now, here again, structure-function relationships are really important. The TTR fibril, the TTR molecule, is a tetramer composed of 4 constituent monomers that are held together at a thyroxine binding site. Now, Transthyretin, as the name suggests, transthyretin or carrier of thyroxine and vitamin A, is exactly the same protein as prealbumin, the same prealbumin that we measure to determine a patient's nutritional status. And it's so termed because on gel electrophoresis, it runs ahead of albumin. It is mostly produced by the liver, and small amounts are produced by the choroid plexus and the retinal epithelium, which again has clinical significance. Now, the mechanism of TTR amyloidosis is that for many reasons, some that we know and probably many that we don't, the tetramer dissociates into its monomeric forms. And the dissociated monomer then misfolds, and the misfolded monomer becomes very aggregation prone and then goes through several pre-oligomer stages or pre-fibrillar oligomer stages before it actually forms the amyloid fibril. Now, this is really important because the infiltrative cardiomyopathy is produced by infiltration of amyloid, but there is also a toxic component. And this is very well established in AL amyloidosis, less well established in TTR amyloidosis, so that cardiac amyloidosis really is a toxic infiltrative cardiomyopathy. Now, the pharmacotherapeutic efforts in TTR amyloidosis have followed sort of the lifespan, if you will, of an amyloid fibril and have focused on suppressing TTR synthesis in the liver, stabilizing the unstable TTR tetramer, and finally removing fibrils that have been already deposited. So let's go through some of these in a stepwise fashion. The first approach to suppression of TTR synthesis was, of course, liver transplantation for hereditary TTR amyloidosis, where the amyloidogenic liver is substituted with a normal liver from a patient without a gene mutation. There have been a relatively few number of liver transplantations performed for this purpose, many more outside of the US, mostly in Europe, and many more for neuropathy than for cardiomyopathy. Liver transplantation retards the progression of disease. It does not reverse. In fact, it's fallen out of favor because today we know that cardiomyopathy can continue to progress of a liver transplantation. And curiously, from the deposition of wild type ATTR that is seeded on small amounts of variant ATTR that existed in the myocardium before the patient had liver transplantation. So this is not something that is done a lot these days. One of the most exciting developments in amyloid has been the introduction of RNA silencers. And this is a very simplistic scheme of protein translation. And as you know, the DNA is transcribed into mRNA. You see that here. And it's the mRNA in the nucleus. And the mRNA is then transported out into the cytoplasm and then translates into the protein through the ribosomes. Now, RNA silencing can occur both in the nucleus and in the cytoplasm. And we have two approaches to this. One is the antisense oligonucleotide, and the second is the small interfering RNA. And they both result in a knockdown, a significant knockdown of the mRNA, resulting in a reduction in TTR synthesis. Now, I wanted to spend one slide talking about a small interfering RNAs because it was such a fantastic development that opens up a whole host of opportunities in pharmacotherapy. Now, RNA interference takes advantage of some natural mechanisms of gene regulation. And it appears that these mechanisms teleologically developed as a defense mechanism to viral infections. And viral infections, as you know, inject double-stranded RNA into the host to take advantage of the host mechanisms for replication. And when the cell encounters these double-stranded RNA segments from the viruses, small enzymes known as dicers snip these RNAs into fragments known as microRNA. So when these double-stranded RNA snipping occurs in the natural setting, these are called microRNAs. And the microRNA combines with certain chemolytic proteins known as argoproteins to form the what is now become very famous is the RISC complex, or the RNA-inducing silencing complex. Now, because the RNA sequence is complementary to this very specific viral sequence, the RISC complex targets and cleaves all the foreign mRNA. Now, when this is created artificially, when these small segments of specific mRNA created artificially, this is what Craig Mello and Andrew Fire did, the synthetic double-stranded RNA is called small interfering RNA, and the sequences can be created to suppress specific gene mechanisms, for example, the translation of TTR. So patisiran was the first agent that was approved. Inotersen is an antisense oligonucleotide that sort of acts in the same way, not identically, but similarly. And both are given parenterally and produce a very significant knockdown in the prealbumin level. So note that if you measure the prealbumin in these patients, the success of the therapy is demonstrated by a fall in prealbumin levels. And this is very important. Now, talk about a number of exciting developments in the same clinical area. Here again, in TTR amyloidosis, we've shown the first time successful in vivo gene editing in humans using the CRISPR-Cas9 technology. This was a phase 1 study reported last year in the New England Journal of 4 patients from the UK and 2 patients from New Zealand, total of 6 patients, given this compound known as NTLA-2001, and showing a permanent and irreversible knockdown of the TTR gene and a reduction in the production of TTR by more than 95%. Note here again that the prealbumin levels fall when you do sequential testing. Now, the CRISPR technology, again, I'm not a molecular biologist, is very, very interesting. And the NTLA-2001 is a nanoparticle containing a single guide RNA. And the single guide RNA is created in such a specific way that it binds to a segment of the TTR DNA. But included in here is an mRNA. It's a bacterial mRNA that codes for something known as Cas9, which is an endonuclease. And when the nanoparticle is dissolved in the cytoplasm, the mRNA encodes and produces Cas9, and it's the binding of the Cas9 in a very specific fashion to the single guide RNA that gives it this name, CRISPR, and it's called CRISPR with Cas9, which is the endonuclease system. Now, the beauty of this approach is that it is a modular format, and the single guided RNA can be used for any gene editing, but this was shown for the first time in TTR amyloidosis. So these are the approaches that have been tried, and some of them successfully and now FDA approved in the clinical realm for the suppression of TTR synthesis. The second approach is to actually make the tetramer most stable, and so that the rate limiting step, which is the dissociation of the tetramer, is inhibited. Now, a little bit more about structure-function relationship. So here is a view of the TTR molecule, and I showed you the 2 tetramers or 4 tetramers seen en face here. But I also wanted to point out that bound to the TTR molecule are retinol binding proteins that carry vitamin A. Now, RBP is a very, very small molecule. When it is not bound to TTR, it's very quickly excreted by the kidneys. And this has an important clinical relevance in that when you knock down TTR by any of the therapies that I showed, patients require supplemental vitamin A administration, or otherwise they will become vitamin A deficient. Now, the many mutations that we know destabilize the TTR molecule, either thermodynamically or kinetically. And another very interesting and a completely serendipitous observation was that of these rescue mutations or kinetically stabilizing TTR mutations. For example, the T119M mutation, which was seen in a group of patients in Portugal with a very pathogenic mutation. So the T119 mutation coexisted with a pathogenic mutation, and these patients did not develop manifestation of the Val30Met mutation. So that was what led to the recognition that this mutation actually kinetically stabilizes the tetramer and opposes the effects of destabilizing mutations. And this again was used in the development of stabilizing agents. So the agents that we currently have are tafamidis and diflunosol. Tafamidis recently approved, Pfizer product, diflunosol costing a few pennies, an age-old NSAID that has existed for a long time. And these two agents stabilize the molecule by binding at the T4 site. Now, TTR is not the main carrier of T4. It's a very weak dimer-dimer interface. Less than 1% of the TTR binding sites are actually bound to TTR, but it is the rate-limiting step for tetramer dissociation, and drug therapy, developments of drug therapy have utilized that fact and utilized the TTR binding sites to stabilize the molecule. Now, one other agent that is currently undergoing phase 3 trials uses the T119 mechanism and actually stabilizes the TTR molecule by mimicking what the T119 mutation says. I know we're getting a little short on time, but the ATTR Act, as you know, showed a significant mortality reduction of tafamidis, and it is now standard therapy of patients with ATTR amyloidosis, both hereditary and wild type, and it has no significant side effects. Note that it takes at least 18 months for the effects to be clinically seen, but when you use a stabilizer, the difference is that the prealbumin levels rise, and I think this might be important. There is now a substantial amount of data that shows greater benefit when the drug is used early. And this is diflunosol, again, as I said, a very cheap agent, but because it's an NSAID, it has all the side effects of NSAIDs, and it is somewhat difficult to use in patients with ATTR cardiomyopathy. Still, we use it in some patients. We've used it effectively and safely, and this was a recent study that showed that with careful observation, it might be used in patients who have otherwise no options for therapy. Now, one of the questions that's often asked is, what is a better approach? Is it TTR knockout or TTR stabilization? And I want to pause here and make a point of the fact that we don't fully understand the physiological roles of TTR. We know it is a secondary carrier of T4. We know that it carries vitamin A, but this molecule is maintained in the body at a very high metabolic cost. Second, there are no natural models of null or even haploinsufficient mutations, which makes most people working in this area believe that it does have an unidentified role. In fact, in large observational studies looking at the T119 mutation that makes TTR most stable, there seems to be an association between TTR stability and freedom from death due to cerebrovascular and other vascular disease. In a purely anecdotal fashion, all of these things that we associate with longevity, for example, curcumin, and that's turmeric, and green tea, and resveratrol, curiously, all of these things have been known to stabilize TTR. And so stabilizing it with increasing prealbumin levels is a more physiological approach to TTR therapy. And I've gotten into trouble for saying this because there's absolutely no data to suggest that knockdown of TTR is associated with any major side effects. So this one I will allude to very briefly, There are a number of approaches that are being currently studied for the removal of TTR fibrils that are already deposited, but none of these, in fact, most of these trials have not been very encouraging, and none of these have translated into the clinical realm. There is a lot of information that is becoming pretty obvious now for general heart failure management. I've listed a number of these here. Beta blockers should be stopped in patients with significant restrictive cardiomyopathy. The old adage that slowing the heart down to improve filling, it now turns out to be a myth, because most of these patients are very dependent on heart rate for their cardiac output. It's really difficult to improve filling in these patients, and they feel much better when beta blockers are stopped. We use a lot of mineralocorticoid antagonists, spironolactone, in all of our patients, because diuretics and MRAs are really the mainstay of therapy for patients with advanced diastolic dysfunction, and of course anticoagulation with a very low threshold. So, for my final slide, TTR therapy has arrived, non-invasive methods of diagnosis has arrived, but patisiran costs $450,000 a year. Inotersen costs $450,000 a year. Tafamidis is the most costly oral therapy to be approved in the United States. And while these developments come with a great deal of enthusiasm, it also raises many societal and sort of philosophical questions. Is therapy affordable? Can we deploy therapy in an equitable fashion? And I will leave you with those thoughts, and thank you so much for your attention.
Thank you very much, Prem. And this was a tremendous overview. I think we have already received, if you will follow in the chat, some very complimentary messages of how wonderfully it was covered. So thank you very much for a very thorough, complex topic, and you covered a lot of the development that has recently happened in a very short period of time. So that was masterly. We'll bring in two of our panelists for today, Dr. Danielle Moyen and Dr. Kenneth Delnawan. Both are our heart failure champions, and we're going to try to have a few back and forth discussions in a panel. So first question that I'll start off saying, Prem, so I think we understand that this disease, when it comes in the forms that you showed, some little bit of effusion, thickened ventricle, I think the burden of responsibility is on the people to recognize that and call it out and send for the appropriate testing. My question is how early we can start picking this up. Mm-hmm. Is all amyloid that infiltrates the myocardium characterized with restrictive cardiomyopathy? Because what I've seen is many times you don't see a typical restrictive, those are the classic patterns, but simple thickened ventricles that sometimes look very benign and not so different from other types of hypertrophy in an elderly person could be amyloid. What are your polls when you're looking? I mean, the first thing is on the echo, and I want this crowd here to be heightened about the need to be vigilant about not missing it out. So what are your polls, and what are the myths about a routine echo being able to pick, and where you should be able to, what kind of patient should you be doing your SPECT, PYP, or MR?
So first of all, you bring up some really important points. If people live long enough, some amyloid deposition is almost a part of aging, right? If you take autopsies in patients who are older than 85 years of age, about 15% will have some amyloid deposition in the heart. And I've gotten into these situations where I've done biopsies of different organs, and there's a little bit of amyloid in the vessels. And what does it mean? So all amyloid is not amyloidosis. And this is why it's really important to do the testing in a clinical context, right? So ideally, the patient who presents with heart failure symptoms, not just community screening of everybody. Patient who presents and has a, what we today call the typical phenotype, and that description of typicality is expanding as we understand this disease. And it is hard because if you take if you take the individual components of the amyloid phenotype, they're all very non-specific. I mean, you see many more patients with LVH than there are patients with amyloid. But this combination of a thick ventricle, particularly with a small pericardial effusion, usually for some reason it's always in the anterolateral wall, I don't know why, with a thick interatrial septum. This combination should make you look at the ECG. And if the ECG shows conduction blocks, a pseudo-infarction pattern, and then the patient has heart failure, bilateral carpal tunnel syndrome, that is, that's sort of the sequence of thinking that we have. Now, very often, and I mean this, very often, we will get referrals from the MR lab saying that there is extensive subendocardial gadolinium enhancement, ECV is high, T1 values are high, this could be amyloid. As I said, the higher the T1 value, the higher the ECV, the more likely it is to be amyloid. But we do see many patients with intermediate degrees of LGE that turn out not to be amyloid. And the same with the apical sparing pattern. The presence of apical sparing pattern is less useful than its absence because the sensitivity is greater than the specificity. So this is what I meant when I said, as when we use diagnostic tests, it's really important to understand this, the performance characteristics.
So if you were to use Prem, heart failure with preserved ejection fraction and atrial fibrillation patients, what proportion of these patients would be amyloid?
Well, the data suggest that 10 to 12% of these patients. Now, these are very, one of the studies, the Spanish study, was an inpatient population, so it's very skewed. Now, it is also important to remember that including PYP, all these tests were studied in these sort of highly specialized referral populations, and we are moving testing now more and more into the community. And so the tests are not going to perform that well. But to answer your specific question, I would say somewhere between 10 and 15% have amyloid.
Okay, so there's a quick question from Dr. Anthony Altabelli. The ideal method and intervals for screening ATTRV carriers remains challenging. What is your practice, and do you screen carriers before expected age of onset of cardiomyopathy for their particular mutation?
That's an awesome question. In fact, I was going to include that in the answer to yours. So the one situation where early detection is useful is when in carriers, right? There's an index patient, there's a proband who's found to have hereditary amyloid, and then we screen the families. So generally, the phenotypic manifestations stays true, at least in families, to the gene mutation. And so we will generally start screening about 10 years before the age of onset of symptoms. In the proband, in the index patient, this is not based on any science. And I would repeat the PYP maybe 2 to 3 years, every 2 to 3 years. And I now have a handful of patients where the PYP has gone from negative to positive. Now, tafamidis is really expensive, right? And we don't really know that treating patients when they have a tiny bit of amyloid in their heart really does anything. At the same time, we don't have any data to the contrary. And common sense and logic would say that when you find it, you should treat it, particularly in patients with hereditary forms of the disease. We're really in uncharted sea in this area. And it's not a trivial consideration because not everybody can afford tafamidis. Sometimes copays run into thousands of dollars a month. And so these decisions are really consequential.
Yeah. Daniels, your thoughts about any of your questions, comments?
That was an amazing talk, Dr. Soman.
Thank you.
My question is regarding some of these amyloid patients with severe, I'm talking the ones who are north of 2 centimeter degree of LV hypertrophy. That's for me, as a heart failure clinician, has been kind of the missing link of how do we induce regression of LVH?
Yeah.
And I'm curious about your thoughts in the future about how we can do that. I know you mentioned the data has been kind of not great to this point, but where do you think we're going with that?
Yeah. Daniel, that needs a glass of wine and 2 hours to discuss, I can tell you. But so my feeling is that not everything in amyloid is caused by the actual infiltrative cardiomyopathy. So if you take AL, for instance, right? When you start treating AL, patients improve much quicker than you would expect from the time it would take to resolve these amyloid fibrils and for sort of remodeling of the heart. My suspicion is that something like this happens in ATTR, we just haven't found it. The other thing, and this is purely speculative, if you look at the approaches of pharmacotherapy that have been successful, they've all been, you either stop the TTR synthesis or you stabilize the TTR. And by doing this, you stop the production not only of the amyloid fibril, but you stop the production of everything before it, all the pre-oligomer fibrils. Contrast that with all the therapeutic approaches that have been tried for scavenging amyloid fibrils, and none of those have worked. Now, we haven't really had a very good trial using that approach, but if you think about it, none of those approaches have really worked. And so it makes me think that a lot of this pathophysiology is not just the infiltration. And I don't know. I mean, when the myocardium is full of amyloid, it's purely speculative. It's not going to go away in a month. It's going to take years, but patients seem to improve much quicker. So I think, remodeling, if you mean, regression of LVH, I don't know whether it'll occur. I don't know whether it'll take that long, but I think there are other things we can change. Another aspect of amyloid that we are very interested in is, why some patients drop their EF, right? You see patients who are LV thicknesses of 2 and 3, and they're fine. Well, they're not fine, but the EF is normal. But 40 to 50% of patients will drop their EF. We can't find any correlation with LV thickness or ECV. There are certain things that make them drop their EF, like they don't tolerate tachycardia, they don't tolerate RV pacing. But in many patients, and so, one of the first things that I did when I established the Amyloid Center was I recruited a basic scientist, because we really wanted to answer these questions. And we biobank everybody, and we are looking at the serum. Is there something in the serum, right? Is it inflammation? Is it something else that causes direct myotoxicity? So it's a very quick answer to a question that I think about a lot, but I'm happy to chat with you again later.
So Kenneth, what has been your experience, Dr. Donovan? I know that in the community, we do see a lot of patients with LVH and referral. And what has been your experience and your questions to Dr. Soman?
So first, Dr. Soman, thanks for that very thorough, very comprehensive review. My question for you is, due to the interest of time, why not use both a silencer and a stabilizer? What is your experience in using both tafamidis with inotersen?
Yeah, it's $250,000 a year for the rest of the patient's life. And that's a lot of money to spend without very firm evidence, right? I have used it. I have used combination therapy. One patient I can remember is somebody who had a liver transplantation for hereditary amyloidosis, developed progressive polyneuropathy, hereditary polyneuropathy, so was on patisiran, and then continued to have wild-type amyloid, which is a very well-known phenomenon because of seeding. And then for the cardiomyopathy, I put her on tafamidis. I'm not sure I'm doing any good because she has very advanced amyloid. I don't know. I think Right now, there's no data to show that the two are additive. And until we can show that very firmly, it will be very difficult to spend that much money.
I agree. Partha, to your question, yes, the more we look for it, the more amyloid we see. In fact, we had a speaker last month, I think he said amyloid is a rare condition, which I agree completely. You just have to look for it for you to find it.
Very good. I think there were a couple of questions which were more from Dr. Yanmala, and I will just quickly put it out there. Oxidative stress and its role in modulating the monomer to amyloid oligomer formation as metals, charged lipids, etc., can shift the equilibrium. And are there any allosteric modulator binding sites identified that stabilize the tetramer state of protein?
Yeah. I know I'm not sure I'm the right person to answer that, but I understand what you're asking, and they're awesome questions. I don't think there are any other binding sites on the tetramer that can be used to stabilize it. AG10 actually causes some very unique amino acid binding between adjacent serine residues, but it mimics the T119 mutation. I am not aware of any other binding sites that can be used. I mean, Jeff Kelly and his colleagues have done such a thorough, exploration of everything that can be done to stabilize the ATTR Fibril, TTR molecule. My knowledge is that I don't think there are any other sites.
Very, very awesome review today. And I think I'm so pleased that everybody has enjoyed hearing you, Dr. Soman and Danielle and Kenneth. Thanks for joining it. I think this dialogue should continue, hopefully in the near future, with some of the tremendous enthusiasm and advances that are surfacing it out. Maybe the whole paradigm will shift. And I think this is one of those diseases which may be an insight to so many other genetic machinery and a future evolution of diseases in cardiology that could be, that were considered challenging, would be something within treatable range. So thank you very much for the overview, and look forward hopefully next time to see you in person, Prem.
That would be awesome.
Yes.
Thank you very much.
Yeah, good.
Bye.
Good
Partha,
night.
thank you again. It was an absolute pleasure. Take care. Bye.
Take care. Bye-bye.